What's going on, guys? So the next drug that we're going to talk about in our series of antihypertensives are going to be ACE inhibitors and ARBs, okay? And so the easiest way to kind of go about this is just to get another overview of the RAS system, renin-angiotensin-aldosterone system, okay? And so basically this is how it goes. So angiotensinogen is produced by the liver. Then renin is produced by the kidney, and these come to form angiotensin-1. Angiotensin-1 is then acted on by angiotensin-converting enzyme, or ACE, to become angiotensin-2. Then angiotensin-2 works on one of two receptors, angiotensin-1 or angiotensin-2. Now these work in the adrenal gland to produce aldosterone. And the gist of everything here is to block the formation of aldosterone. And the reason why I'll get to in a second. So two things. First of all, angiotensin-2 is a vasoconstrictor. And second of all, angiotensin-2 will act on its receptor to increase the production of aldosterone. Okay, now, so what about aldosterone? Well, let's think about the physiologic function or the normal function of aldosterone. Aldosterone works to, first of all, reabsorb sodium and dump potassium. Okay, so this is its normal function. As always, think about this. Water always follows sodium, okay? So water will be reabsorbed along with sodium. Now, if we block the formation of aldosterone, what is that going to cause? Sodium won't be reabsorbed, potassium won't be excreted, and water will follow. And kind of like the same mechanism that we had with thiazides, if we let go of sodium, that'll increase the excretion of water. The excretion of water will decrease the amount of plasma, and that'll lower the blood pressure. Okay, so that's it. Now, angiotensin converting enzyme inhibitors obviously are going to work here. And our angiotensin receptor blockers are going to work right here. And so, like, you may be asking, it's like, so we have two drugs that basically do the same thing, but why use one over the other? It's a very good question. Okay, something else I should probably mention is that ACE inhibitors have the suffix pril. So these are going to be enalapril, captopril, etc. And our ARBs are going to be sartan, losartan, valsartan, things like this. Okay. So as any drug that we talked about mechanism. Now we talked about adverse effects. So the mnemonic here with ACE inhibitors is going to be catch. Let me do this in red here. With two H's. Okay, so the first one is going to be cough. Now, whenever you see a patient that has hypertension and they're on an ACE inhibitor and they have this chronic cough, and the question may be like asking you, what is the mechanism, or what is the most likely reason, or what drug in their regimen is causing this cough? It's going to be ACE inhibitors. And then the question might be asking you, what drug can you change it to that wouldn't produce the cough? Then you first of all, you would know the cough is caused by ACE inhibitors, and then the drug to change it to would be an ARB, to be an ARB. Okay, so the second thing here would be angioedema. So obviously this would be contraindicated in a patient who had hereditary angioedema due to C1 esterase deficiency. Okay, another one, the T is going to be teratogen. So ACEs and ARBs are both contraindicated for patients who are pregnant. What about C? C is going to be an increase in creatinine. And the reason why is because as we decrease the plasma, this will decrease GFR. Okay, but for the context of antihypertensiveness, this is what we're gonna focus on these ones. So what is H? Hyperkalemia. Why hyperkalemia? Well, remember, the physiologic function of aldosterone was to dump potassium and reabsorb sodium. So if we're not blocking potassium, then what's going to happen? There's going to be a buildup of potassium. That's basically it. So if you understand the normal physiologic function of aldosterone, then the thought behind, or the rationale behind why there would be an increased amount of potassium, it makes sense. And then the last one here, well, maybe I'll write it right there, is going to be hypotension. Which also makes sense because we have decreased the amount of sodium being reabsorbed by a very powerful hormone, aldosterone. And so we have the intended effect of decreasing the plasma volume, but again, it can go it can be too much. Okay, so these are for our ACE inhibitors. So what about ARBs? So for our ARBs, obviously, first one is going to be hyperkalemia, because again, the function of both of these drugs is to inhibit the formation of aldosterone. So hyperkalemia is going to be one. Hypotension is going to be another one. And again, teratogen. So both these drugs are contraindicated in pregnant women. Okay. And then there's one more thing, and is that ACE inhibitors do something specific to something called bradykinin. Okay. So ACE inhibitors decrease the inhibition of bradykinin. Which is kind of like a weird way to think about something, where it's like if you normally ACE inhibits bradykinin, but if you inhibit ACE, then that inhibits the inhibition of bradykinin. Well, just to say, the amount of bradykinin will increase. And that's why with ACE inhibitors, you get the angioedema. Now, the thing about sartans is that the thing about ARBs is that since you're affecting the receptor and not the enzyme itself, it doesn't cause the same thing. So in a patient with hereditary angioedema who also might be having hypertension, ARBs would not be contraindicated in that patient. And that's it.